So let's say talk about infection. So, the chance of that happening is probably about 1%. So, 1 in 100 patients might have an infection afterwards. And that could occur quite some time after surgery, not necessarily straight away. And, I mentioned that we do an awful lot to try and reduce the risks of having an infection in the first place. So we give antibiotics intravenously at the time of surgery and sometimes afterwards. We might put, if it's a cemented hip replacement, there might be antibiotics in the bone cement. The operating theatre we work within is ultra filtered air, so it's sterile air in the operating theatre to try and reduce those risks. The surgeons will often wear a kind of a spacesuit, to try and exclude skin scales from the surgeon, and all those things are all about trying to reduce the risk of infection. Patient may have been given skin washes beforehand to try and decolonize skin. They might have had a swab for MRSA before to make sure they're not a carrier of MRSA. All these things are about trying to reduce that risk. Mm-hmm. But even with all of that, the risk is still there, and it's probably about 1%. And the problem with infection is if you get infection in a joint replacement, the bugs sit on the metal or on the plastic or on the ceramic or whatever it is, and your body can't get rid of that infection. And giving antibiotics won't get rid of that infection because there's no blood supply to the metal. So your immune system can't access it. So you might have antibiotics and that might suppress it, but ultimately if it's a real deep infection on the implants, then the only real option then is surgery, more surgery, to take the implants out, to wash out the area, potentially then put a new hip replacement in at the same time, and that would be called a one-stage revision, or to take the implants out, put a temporary hip in, or even no hip, and then leave that to heal up, and then go back some 6-8 weeks later when everything's settled, and then put another hip replacement in. So real deep infections do sometimes lead to the necessity for further revision operations.
And you mentioned that the sort of overall the risk of an infection is roughly 1 in 100. Where in the cases where an infection does occur, within that group, what is then the risk of that going on to requiring a revision for a deep infection?
So I think I think the 1% is the sort of deep infection risk. Right. Okay, so you can have superficial infections. The wound might just look a little bit red at some point. You might see a GP and it might give you some antibiotics, and they give you some tablets for a bit and it settles down. That might be a superficial sort of, which is a much less serious infection. Mm-hmm. But what we're really talking about and what we're really worried about is the real deep infections, which would, the vast majority would need revision surgery. Yeah. But the success rate of revision surgery in that situation is very good. So again, there's a 90% chance of getting rid of the infection mm-hmm. with revision surgery for infection. Okay. So obviously that, if you do your maths, that means that there's a 10% risk of infection when you're doing a revision for infection, which is 10 times higher than it was at the beginning. Yeah. So, so there are treatment options, but I suppose this conversation now is probably going a little bit further on than we would do in a normal clinic situation because we've got the time. But I think that's the value of this, is that we can perhaps go a bit deeper. Yeah. So a patient might say, well, what happens if you can't get rid of the infection in a revision? We might need another revision. And then another revision, and it might not come back, and then you might have to have, take all the implants out completely and not put any more metalwork in there. Or it might be a multi-drug resistant bacteria that you get an infection, and that's very difficult. So, ultimately, in the really, really severe cases, it can be that you can't put another hip in, and the patient ends up, with what we call a pseudo, which is short for a pseudoarthrosis. And patients actually can be reasonably mobile. Obviously, they live left with quite a short leg on that side, requiring mobility support with crutches or a Zimmer frame. But it's not necessarily meaning that they have to be in a wheelchair all the time. But the chance of getting to that stage is really, 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 really small. But we do see patients that have been in that situation.